Hello, I'm Olga Dobrovolska from Bookimed, and today I have a pleasure and honor to have speaking with Mr. Ari Raphael, an expert in oncology treatment from Israel. So thank you so much for joining us in this important discussion. And today we're going
You're
to
welcome.
talk in particular about treatment of the breast and lung cancer. So, for many patients, the cancer diagnosis, it sounds like some death penalty, death sentence. So, could you tell us, please, what are like three common mistakes in cancer treatment approaches that you have observed in patients who began therapy in other countries, not in Israel?
So I think that the main mistakes that I've observed was, first of all, a wrong diagnosis, starting from the pathology report, which is, of course, crucial for the rest of the way, the rest of the treatment. I've also experienced underdiagnosis, meaning that the pathology was correct, but the staging of the disease, because it's very important in cancer to know exactly how extended is the disease. And in case that we have an underdiagnosis, it means that we can be too aggressive locally, but we are missing disease which is already escaped, and then makes us to be too aggressively locally, but it's unnecessary, and we're missing time in treating the extended disease. And of course, sometimes there are no access to new drugs or new therapies, and,
Mm-hmm.
uh, and there are no good multidisciplinary teams, meaning that in Israel, in any case, uh, we are going as a team with the medical oncology, radiation oncology, the surgeon, and the radiology, and so on, and sometimes even the pathology. And we are as a group deciding together how to treat, and it's not just one-on-one. Because if you will only meet a surgeon, will take you probably to surgery, and maybe you should have received therapy before the surgery, and so on.
I see. I see. Thank you so much for sharing that. You mentioned new drugs, yes, new approaches in treating cancer. So, could you tell us more about those drugs, about those approaches, how you use it, and what effect did it give to the treatment process and treatment result?
Okay, so I will give the medical oncology point of view, of course. So mainly we're talking about novel drugs, um, but also about novel strategies. Regarding drugs, so in the past 5 years, um, obviously we are talking about the checkpoint inhibitors, anti-PD-1, anti-PD-L1, anti-CTLA-4, which is a bit older, and now newer drugs such as LAG3 and anti-TIGIT, which are always basically to help our immune system to attack better the cancers. And that's what we call immunotherapy. Uh, Other than that, we have the targeted therapy, which are treatment that are going after a certain operation, whether it's a mutation, translocation, and so on. Of course, also here we have newer drugs, and especially in lung cancer, we are already familiar with approximately 10 aberration, the classic EGFR, but also ALK, ROS, RET, BRAF, MET exon 14 skipping mutation, MET amplification, and I can go on and on. But we have a targeted therapy, which more in never or former smokers in lung cancer. We also have some targeted therapy in breast. And another technique or strategy we have is a ADC, and the antibody drug conjugate, which are molecules that are consisted of three parts. We have the targeted therapy, will be a monoclonal antibody usually, and a linker and a payload of chemotherapy, which helps entering the chemotherapy better to the cancer cells and its environment, which allow us to give higher amount of chemo with less toxicity. Beside that, as if we're speaking about strategies, so we are going more and more to neoadjuvant settings, meaning we're going to, in the local settings, we're going to try to treat the patients before surgery, and hopefully to achieve what we call a PAS-CR, pathological complete response. It means after we arrive to surgery, we're not going to find any remnant of the cancer in the surgical preparate, which correlates with much better prognosis. And for us, it's a very good marker. We also have a lot of clinical trials here, and also we do intratumoral injections, but this is only in the clinical trial setting.
So, and using these approaches, I believe they result in high success rate of treating breast cancer
So
in particular. Could you share with us the numbers? What is the success rate of treating breast cancer at various stages in Israel in particular?
So it's obviously it's individual, and it's mostly depend on the stage of the disease. I have to say that we are pretty much having the same number in the literature of the clinical trials number as in the US, in the United States. Um, but again, we're gonna be alert and catch the cancer earlier. The prognosis will be much better. If it's already a metastatic disease, even with the newest drugs, the chances for a prognosis, I mean, the prognosis is obviously much poorer. But even with that, we can, in some of the cases, achieve good and long-term responses. In breast cancer, for especially mainly in the HER2 uh, subtype population, and with the anti-hair therapy over there, we can achieve really long-term, and we can even say we can call it a curable disease in some situation, and also in lung cancer, even in the metastatic setting, in case of a very good durable response to checkpoint inhibitors, we can also start to speak some of the cases about meaning that
So,
there is hope even for nowadays, even for metastatic patients.
so as you mentioned, like the early detection, yes, of the cancer is crucial for the successful treatment. And if we talk about breast cancer, so could you tell us what are the early signs of it? And what tests should patients undergo for early detection of this cancer?
Okay, so in breast cancer, a lot of the discoveries are from screening mammographies. And it's an old but very useful tool. And of course, I can use this stage to recommend to all the women um, from age 50 and above, but even before. I mean, we are starting to go with this number earlier. And of course, if there is cases in the family, or of course, if there is a known mutation such as PRCA1 or 2 or check and so on, then the screening should start earlier. And beside mammography, we add other modalities such as breast MRI and so on. There is also an option for a personal checkup, and the woman can do a personal examination, easy, and it sometimes it can help earlier detection. Other from that, blood check, CT or PET scans are not proven to be successful in breast cancer. So they are not commonly recommended. Of course, if there is accidental increase in liver function or a certain pain, it needs to be yeah. So as I said, mostly mammographies, sometimes a personal check or a check by a surgeon. These are usually the how breast cancer is being diagnosed.
Thank you so much. Thank you so much for sharing that. It is really important for me, for women to know what to do and how to react if they suspect something is going wrong. So when it happens, yes, that women they have cancer, is it possible for them to preserve affected breast? Because I believe that this is their the most fear that they are going to lose it.
Conserving the breast is it's very important to the patient, and the science today is giving a lot of effort how to do that, but it shouldn't be in any cost. Meaning that, of course, we are only speaking in local disease, okay? Because in metastatic disease, we are not talking about removing the affected breast. So, but in cases of a local disease, that it really depends on the size and the location of the tumor, and that you have to compare to the side of the breast. In case that a lumpectomy uh, is possible, uh, then usually this is a strategy. Sometimes we can offer a treatment before the surgery, if for downstaging and for better cosmetic results. And then we are going for a lumpectomy, and usually we add, depends on certain parameters, but we add radiation therapy to replace mastectomy. If we do have to do mastectomy, then there are options of reconstruction. It can be during or after surgery, depend on the case.
So basically, it is possible to have the breast reconstruction immediately during the surgery.
We have a certain surgeons that are specialized in that, and they're doing what we call the oncoplastic, and we can involve in the surgery itself also a plastic surgery inside, and it is possible, but it's not always recommended. So it's really case by case.
I see. Thank you. Thank you so much for sharing that. And is it always possible to reconstruct the breast? Or in some cases, it is impossible to do?
Usually, and in most cases, it is possible. In one of the cases, it's not possible, but usually we are able to do that. If not immediately, then later.
In terms of prophylactic mastectomy, so do you perform it?
So we do that in a very certain cases. Uh, we tend to do that in BRCA 1 or 2 carriers, in a patient that was already sick once, and the cancer was removed. Maybe we can do in that the same surgery. We can do bilateral mastectomy, or we can do it later. And she should be a younger patient, because you will have more time to enjoy this surgery. Enjoy meaning um, less chance or more years for the cancer not to recur. I have to say that even if you do the mastectomy, it doesn't say necessarily that the cancer won't return, because even when we perform the mastectomy, we do leave even up to 10% of normal breast tissue, and the cancer may return in that. And it absolutely doesn't replace follow-up. I mean, even if a patient did a bilateral mastectomy, she will still have to perform a yearly follow-up, imaging and physical examination.
So based on your experience, could you share with us if it is possible to cure the stage 4 breast cancer?
Um, it's not easy at all. There is a chance. But in subtypes, certain subtypes of this disease. So the best long-term result in the metastatic settings we see in the HER2-enriched subtypes, meaning that the cancer will have a HER2 positive receptors, and then we can offer a dual anti-HER therapy with trastuzumab and pertuzumab, what we call the Herceptin Perjeta. So personally, I have several patients who still receive this therapy for much more than 5 years, and if 5 years is um, the border that after that we can start speaking about the word cure, then we have more than one. In triple negative breast cancer, the chances are much, much lower, and very, very few people, patients, uh, perhaps those with a high PD-L1, positive PD-L1, that will receive checkpoint inhibitors. Sometimes some of them have long time and durable responses, but we still don't have enough follow-up for these treatments. In luminal breast cancer, what we call the hormone receptor positive, um, also there with the CDK4/6 inhibitors, Palbo, Ribo, or abemaciclib, with this therapy. So now we have the overall survival after 5 years follow-up. So also there we see people who order 5 years. We can call it a cure. I'm not sure yet. And what's for sure is that these people will have to continue this therapy as in a chronic disease.
Thank you so much. Thank you so much for sharing that. So, we were talking mostly about the breast cancer, but you also your core expertise is lung cancer as well. So, could you tell us, please, what is the success rates for treating lung cancer at various stages in Israel?
Okay, so again, such exactly as in breast cancer, the earlier you will find the disease, the better chance you have to survive. Unlike breast cancer, which most of the women will be detected at the early stage, lung cancer, unfortunately, more than 50% will be detected in a advanced or metastatic setting. This is because we do not perform good screening, and usually when the symptoms arrive, uh, it's already a very advanced disease. So in the very early stages, we can offer cure in high rates. Nowadays, in the locally advanced disease, we are getting better. We're improving in the results. We offer better neoadjuvant with checkpoint inhibitors, or adjuvant therapy with checkpoint inhibitors, or a targeted therapy, such as osimertinib for EGFR mutation exon 19 and 21 mutation. Over there, we can offer also adjuvant set biological effective therapy. And for the metastatic settings, which is, of course, the poor result. So over there, we also have a variety of success rates. First of all, if the patient has a targeted aberration that we can offer an EGFR agent or Alcross and so on, so we can offer that. But if the patient can receive this treatment for even a couple of years with very good quality of life, taking pills at home. Usually the disease will find a way to resist the drug eventually, and then we have very little to offer the patient. In the patient without the cancer without that are not oncogen driven, the strategy is based on checkpoint inhibitors, and then we try to put our patient on first-line clinical trials. Usually, we'll give chemo-immuno and a new immuno drug. But even for those that will get chemo-immuno or immuno alone, uh, around 20 or even 30%, depending on the PD-L1, will reach 5 years survival, which are amazing results according to where we were 5 years ago, when the median survival was only a year. And we're looking forward for a new and novel drugs to improve even results.
You mentioned that when it has symptoms, usually they are like advanced stages. So
Mhm.
can it be detected or somehow like suspected by the patient at early stages?
Right. So they are usually when the symptoms are usually can be a cough, a dyspnea, or even hemoptysis, I mean coughing blood, and this is already usually the cancer is advanced or very close to a main bronchi. What we have is a screening tool with a non-contrast low-dose chest CT. Based on two very large trials in the US and Europe, we offer several checks for high-risk patients, usually patient above 50 years old, heavy smokers, or former smokers. I mean that smoked no more than 15 years ago. Then we recommend this check, and we several check. Um, the check is still not commonly done in Israel, but we are now entering it as a pilot. The problem with this check is a lot of false positivity, meaning that we can find a nodule and biopsy it, and it won't be cancer at the end. Then we are doing unnecessary checks. But of course, the best thing we can do to prevent lung cancer is to stop smoking.
So this is the most common reason, yes, for the lung
Absolutely.
cancer,
Mhm.
smoking. Basically, if we talk about the treatment of breast and lung cancer, so could you tell us what is the primary difference in treating it in Israel and other countries?
So in Israel, we are tend to use the same protocols and as in the US and some of the Western countries. I have to say that in Israel, perhaps it's the Israeli way. We are trying to be more creative in using and not going and treating just by the paradigm. Um, we are trying to bring all the newest drugs and all the newest clinical trial. We are always working as a multidisciplinary team, as I explained before, with physicians from different disciplines in order to make the best decision for the patient, not just a one-on-one decision. Um, we try to use a best way to follow up the whether it's the PET scan or even liquid biopsy. We recently started to use in order to do better monitoring. Um, and again, all the time to be with the uh, with the foot on the gas and try to get best therapies we can bring.
Have you ever had patients who was considered untreatable, yes, in their home country, for example, and then they have fully recovered after receiving treatment in Israel? Do you know such cases?
So I have several examples. One of my the best example I can give um, was regarding a female patient with a local breast cancer and triple negative, which is unfortunately the worst subtype. And after several removal, she had another recurrence. Uh, and after certain recurrences that you cannot remove anymore, and this recurrence happened also after receiving a adjuvant chemotherapy, usually starting to become very resistant, and usually the local approach does not help anymore. We have to start them even if there is no metastatic visual disease. Have to give systemic therapy, and she did receive, and it didn't help. So that was the patient that came from abroad. We managed to enter her to a clinical trial. In the clinical trial, I did it myself. I injected a novel drug directly into the what we call intratumoral injection, which was an approach that people tried at the late 80s and early 90s, but wasn't successful, and it was left aside, but now it's starting to return. So what we did local injection together with the systemic intravenous checkpoint inhibitor. And she had a inflammatory response in the breast. Uh, we took her to a mastectomy, removing the rest of the breast. We managed to do it with good borders, good resection. We radiated, and after that, we continue with her checkpoint inhibitors to complete 2 years. She just finished last week. Um, and since in the whole time she's without any evidence of disease. It's a very rare uh, phenomena in this scenario. And I'm positive that if she wouldn't come here, then today the situation will be totally different. Now she's stopping therapy and she will enter only to a follow-up phase.
Thank you for sharing your experience in such successful case. It's really important for our patients on Bookimed to find out about it. So, upon receiving a lung or breast cancer diagnosis, would you recommend patient to start treatment in their home country or to travel to Israel immediately?
So I really think it's depends. Um, where do you come from, and what is the uh, facilities you have at home, I mean the medical facilities. Um, Here in Israel, we work in the center of Israel, especially in the Tel Aviv and near area, in what we call tertiary hospitals. It's big hospitals with very big and experienced staff. As I said before, I think it's very, very important that the team will be experienced and will work together. If this is something a patient can have back home, you may try. Of course, it never hurts to get a second opinion. But if it's a complex case, I highly recommend to come to Israel or to another advanced country or hospital to do that, and not to do it in um, a local clinic without that cannot offer the multidisciplinary approach.
Thank you, Dr. Raphael, for sharing this. Well, basically, it was my last question for today. And your knowledge, your experience, it's not just important for us, but it is really vital for our patients and for our medical coordinators at Bookimed, because we are tirelessly working to find the best care and best solution for the patients. Thank you so much for joining us.
Thank you for
Yeah,
having me.